All right, very good evening, everyone. So we are here on May 5th, and it's all the time we have been waited for. I extend a very warm welcome to our esteemed guests and a very warm welcome to all our audience for joining in tonight for our session on bempedoic acid with the clinical implication established through clear outcome trials. I'm sure this session is going to be a lot of learning for every one of us, where we have our eminent speakers on board and to enlighten us on the usage of bempedoic acid, which is a very new drug. So I'm sure some of you would be knowing about very well about bempedoic acid. However, those who still do not know, not to worry at all, my friends. Our speakers are here. Our esteemed board is on there to explain us and enlighten us in the usage of the bempedoic acid. So not wasting any more time further, I would request my colleague and our medical affairs, uh, uh, Dr. Partha Sarthi Muralidharan, to have a round of introduction to all our esteemed guests and kick off the session tonight.
Thank you so much, Robin. Yeah. Taking over from my friend Robin, uh, I have the honor of introducing our esteemed moderator for the day. We have Professor Dr. Sadanand Shetty, who's Emeritus Professor at Dr. D.Y. Patil University in Nerul, the Director of Department of Cardiology, Somaya Super Speciality Hospital, the Chief, the CMD and founder of Sadanand Healthy Living Center Limited, National Advisor to the Lipid Association of India, and the past president of the very reputed Cardiology Society of India. He's also a fellow at the American College of Cardiology, fellow European Society of Cardiology, and a fellow at the European Association of PCI. Mr. Gulati, next. As our distinguished speakers for today, we have Dr. Kaushik Ray, who's Professor of Public Health, Department of the Public Health and Primary Care, Imperial College London, honorary consultant cardiologist to the Imperial College NHS, president of the EAS, chair of the World Heart Federation Cholesterol Roadmap for 21-22, the national lead for CVD NIHR academic research, and multiple more distinguished perspectives to his name. Next. We also have Dr. J. Elilan, who's a senior consultant cardiologist from Madras Medical Mission, professor of cardiology and head of the Department Pondicherry Institute of Medical Sciences, fellow in interventional cardiology at Escorts Hearts Institute, delivered numerous lectures on topics across cardiology, be it hypertension, heart failure, CAD, atherosclerosis, etc., and has chaired various sessions at national level conferences. On the same note, I hand over to our esteemed moderator to take over the session. Professor Shetty, over to you, sir.
Yeah.
So I believe the last slide only is visible.
Yeah, I know. I just,
Yes. Yes, sir.
Can you otherwise put my slide you have got, Parthasarathy?
Same. Sure, sir, I will do the same. I will do the same. Robin, you'll have to give me access, my friend.
I'll side with no problem. You can press the home button, sir.
Yeah. I know, but I'm just trying to do that.
Uh,
Sorry.
no worries. I'll share from my end.
You can just this one anyway. Till Parsarthi shares my slide. Thank you, Parsarthi, Robin, Team MacLeod for keeping this very important session today. As we all know, BEMPEDOIC acid. Can you hear?
Yes, sir. So now
Can you hear me?
Yes, sir. We are able to hear you.
Or now it is mine. Okay, is it coming? It's okay. Yeah, now you can hear, isn't it? You can hear me.
We're having some crosstalk going on somewhere. I'm not sure where it's from.
Yeah, who is?
Dr. Rahul Jain, is this at your end? Professor Dr. Rahul, can you mute yourself?
I think keep all the people mute, Okay, can you hear
Can
me?
we all mute ourselves? Yeah, please.
Can you hear me?
Yes, sir. Yes,
Thank
sir.
you.
Yeah.
Thank you,
Yes, sir,
Parsarthi, Robin, Team MacLeod for keeping this very important webinar today. As we all know, after the clear outcome, bempedoic acid is becoming one of the important non-statin molecule in dyslipidemia management. And as we all know, the problem of adult dyslipidemia in Indian population, this is one of the study which is about almost 9 to 10 years ago, called in ICMR in-depth study, wherein the various types of dyslipidemia have been observed. Like you have hypercholesterolemia, we have hypertriglyceridemia, we have low HDL. So it is quite a very prevalent problem in our country. And as we all know, Indian dyslipidemia is slightly different than the Western dyslipidemia, wherein we have high triglyceride, we have low HDL, and we have a small dense LDL. And that is why our therapy becoming difficult, like when we are talking about LDL reduction alone, whether, statin alone is enough or not. So that particular, the question comes. And therefore, today what we are going to address predominantly the non-statin agent. Dr. Izilan has been introduced by our Dr. Parsarthi. He is going to touch upon basically ezetimibe, which is one of the important non-statin agent for us. And recently, we have bempedoic acid, and particularly Kaushik Ray, who is the principal investigator for this particular trial, and which has shown very clear benefit in the outcome. So Dr. Kaushik is going to touch upon the bempedoic acid and its implication in our practice. Just to give you brief about the bempedoic acid, we know when you look into statin, it is between the HMG coenzyme A inhibitor, the is here which is inhibited by statin. You see here HMG CoA converted into cholesterol, and one step before that is a place where bempedoic is going to work. Of course, Dr. Kaushik is going to inform us in detail exactly what this molecule is about and how to use in our routine practice, particularly after the clear outcome data. We know that bempedoic is a prodrug which is activated into the active drug by this ASCVL enzyme, and then the ACL is one which is converts citrates into acetyl-CoA. Here is the action of the bempedoic, and therefore one step before the statin. And in general, why bempedoic is useful to us, particularly after the ezetimibe, it is one of the important new drug showing the outcome benefit. Importantly, besides the LDL reduction, it has also effect on the HRCL, which is important, the marker of inflammation. And as we all know, dyslipidemia and the inflammation are the two important markers or important pathophysiology for atherosclerosis. So also it does have effect beyond LDL, like reduction of the non-HDL and the ApoB, though it doesn't have too much effect on the TG, but because of the ApoB and non-HDL, it is another additional for us, particularly Indian dyslipidemia. Less muscle or no muscle side effects because of the ACL enzyme is not there in the muscle, which I showed in the previous slide. And of course, is a more of a friendly to glucose, like, unlike the statin, which is, considered as probably diabetogenic in some individual with, strong family history, obesity, etc. Whereas in case of bempedoic, it is, very beneficial in this particular area. And of course, very important drug. We have written a consensus statement few months back, which has come in one of the prominent journal of India called JAPI. And also our consensus statement has been quite accepted now by even the NLA and even the other Western the guidelines. And it has become a very important molecule today, particularly after the clear outcome study, and which, Dr. Kaushik is going to address us further. So friends, we are going to have very, very useful information about the non-statin agents. And the first non-statin is ezetimibe, which is going to be discussed by Dr. Izilan. And then Dr. Kaushik Ray is going to talk on bempedoic acid. And then we will have a panel discussion and the delegate interaction. With this, I would like to close my topic, and I would like to now hand over to Dr. Izilan for the further proceeding. Yeah. Izilan.
Thank you, Dr. Sadhanand Shetty, sir, for your introduction. Basically, I mean, the main talk for today is by Dr. Kaushik Ray on bempedoic acid. And my role is just to show why we need drugs other than statins. That is the need for non-statin agents. I mean, if you look across the globe, 30% of all-cause male death is due to cardiovascular disease, and 25% of all-cause female death is due to CVD. Now, this is not constant across the globe. This is going on changing. If you look at the percentage change in age standardized CVD death from 2010 to 19, for this 10 years, if you see, the areas which are light green, dark green and all are places where the incidence of CVD is coming down. So in Western countries like US and UK, Russia and all, the incidence of coronary disease is coming down. But whereas the areas in orange and brown, where India also is one of the country, you see it is still increasing. So India is one of the countries where the incidence of coronary disease is still on the rise by 10 to 15% every year. If you look at the globe, India has the second highest rate of cardiovascular death in the world. Of course, China is above us, but I think soon we are going to overcome China in population and in cardiovascular death also. So we'll become number one, which is a sad thing to happen. And if you look at the deaths, in China, it is 4 million per year, whereas in India, it is around 3. And other countries are hardly less than 1 million per year. Now, if you look at the key modifiable risk factors for this high CV death, it is 3 main factors. One is high blood pressure, 2 is dietary risks, bad food habits, and 3rd is high LDL. So LDL is one of the 3 important reasons for this high cardiovascular death. And naturally, controlling your LDL will definitely help us to reduce this cardiovascular death. If you look at the paradigm shift in human evolution in recent years, from this state to this stage, where we were thin-built, our blood cholesterol lipid levels were all normal or good. From that, we have become fat, obese with high lipid levels. And if you see, the 2 main reasons for transformation from this to this is mainly our bad dietary habits and lack of physical activity. Now, does this scenario pen differently for Indians? More India, definitely Indians and the Asians as such, we have more visceral obesity. That is, we appear to be thin, but we are having more fat in our body. Then we have clustering of metabolic risk factors. We have atherogenic dyslipidemia, increased LDL, decreased HDL, and triglyceride. This is also known as atherogenic dyslipidemia or the Asian dyslipidemia or Indian dyslipidemia. Cardiovascular disease accounts for 24% of all deaths aged 25 to 69 years. We developed vascular disease 10 years earlier than Western counterparts. So coronary disease happens a decade earlier in Indians. And the disease also is very extensive. We have more multivessel disease, we have diffuse disease, our coronaries are small. And so the management also becomes difficult for CVD in India. If you look at the effect of cholesterol, it is not only the levels of cholesterol, but it is also the cumulative, and it should be seen as cholesterol years. For example, if you have severe hypercholesteremia, like as in familial hypercholesterolemia, maybe even at the end of first or second decade, you developed ACVD. But whereas if you have moderate hypercholesteremia, it takes 2 to 4 decades to develop ACVD. Moderate hypercholesteremia from adulthood, maybe in late 60s, you develop coronary disease. But whereas if you have your lifelong LDL levels and well under control, you have good genetics, you have excellent lifestyle, and you initiate LDL lowering therapy very early if needed, then maybe you will live long. So it is cholesterol years that causes ACVD. Now, absolute LDL-C lowering correlates with CV risk reduction. This meta-analysis of 14 trials by the cholesterol treatment trialist collaborators has shown that by decreasing cholesterol level by 1 millimole, that is 39 milligrams per deciliter, you can decrease the major coronary events by 23% and major vascular events by 21%. So decreasing LDL does produce benefit. And the secondary prevention studies of various statins like the 4S, lipid care, HPS, and TNT all have shown that if you are able to bring down your LDL to lower and lower, say up till 70, definitely you can bring down the cardiovascular events and mortality due to CVD. But patients who have dyslipidemia, even if you give statin and you bring down LDL to the goal, does it absolutely prevent mortality? No. You can see in all the statin trials, there is a residual risk. And the residual risk is to the tune of 75 to 80%. So in spite of giving statin, high dose statin therapy, in spite of bringing LDL to the goal, whichever the guidelines say, still 75 to 80% of the people will have residual risk to develop coronary disease. So obviously this says that statins alone are not enough. You need to act on this residual risk also. So they slowly started giving drugs other than statins. If you look at the IMPROVE trial, where ezetimibe showed that you can decrease mortality compared to statin alone, then when you give simvastatin plus ezetimibe. And the Fourier trial with evolocumab showed that definitely you can bring down the mortality from 14.6 to 12.6. And similarly, ODC outcomes with alirocumab also showed that when you give along with statin a drug, it can reduce the mortality. Then this racing trial showed that combination therapy versus high intensity monotherapy. Instead of giving statin alone at high dose, when you give statin plus ezetimibe, you are definitely able to reduce the primary endpoints. So the numbers here are other way around. With the isolated high dose statin therapy, it was 9.9%. When you combine it with ezetimibe, it is 9.1%. So definitely, when you combine statin plus ezetimibe, you are able to decrease the primary endpoints. Then if you look at the combination therapy, higher proportion of patients achieved LDL less than 70 and the discontinuation or dose reduction was also less. So when you give, compared to high dose statins monotherapy, when you give it along with statin plus ezetimibe, in 72 to 75% of the patients, you are able to achieve the LDL-C goal at 1, 2, and 3 years. But whereas if you give high dose statin monotherapy, only in 55 to 60% you are able to achieve the LDL goals. So definitely more people will achieve LDL goals when you combine a statin with the ezetimibe. And the lower intolerance or drug discontinuation is there when you give combination therapy. So if you look at the discontinuation rate, when you give high intensity statin as monotherapy, rosuvastatin 28.2% discontinued. But whereas when you give rosuvastatin 10 and ezetimibe 10, then only 4.8%. Almost 50% were able to continue the drug. So seeing all this, the ESC guidelines recommends high dose statins, and it also gives a target. And this was for the first time that the target went below 70. Previously, we thought 70 was the lowest which you should achieve. Here, the ACVD risk score that they see is the score system. According to the score system, if your risk for is less than 1%, then you are considered as low risk. You need to have a LDL level of 116. If your score is between 1 to 5%, and you have type 2 diabetes less than 50 years, or your duration is less than 10 years, you are considered as moderate risk. You should bring your LDL to less than 100. If you have a score of 5 to 10%, and you have moderate CKD, EGFR 30 to 59, then or diabetic for more than 10 years duration, you are considered as high risk. Then you should bring your LDL to 70 milligrams. If your ACVD score, if you have ACVD or if your score is more than 10% and your EGFR is less than 30, you have target organ damage and diabetes duration of more than 20 years, you are considered as very high risk and you should have your LDL to 55. So this was the first time the ESC guidelines which aggressively said that you try to bring your LDL to less than 55 in very high risk patients. So these were the targets for low risk less than 116, moderate risk less than 100, high risk less than 70, or at least more than 50% reduction. And for very high risk, less than 55 and more than 50% reduction. If you look at the Lipid Association of India 2020 risk stratification, we are still more aggressive than the ESC. So here they identify as major ACVD risk factors. That is, if your age is more than 45 in male or more than 55 in females, if you have a family history of premature ACVD, if you're a current cigarette smoking or tobacco user, high blood pressure and low HDL. These are considered as major ACVD risk factors. Then you have other high risk features. That is, if you have diabetes with one of these major ACVD risk factors or target organ damage, if you have CKD stage 3B or 4, familial hypercholesterolemia, extreme of a single risk factor, if your coronary calcium score is more than 300 Helmsfold units, if you have non-stenotic carotid plaque, then these are considered as other high risk features. And moderate risk, non-conventional risk factors are your coronary calcium score between 100 to 299, increased carotid intermedial thickness, your lipoprotein A level of 20 to 49, impaired fasting glucose, increased waist circumference, ApoB more than 110 milligrams, and HSCRP more than 2 milligrams. Now, once you have identified these risk factors, then you classify them into low risk, moderate risk, high risk, and very high risk, and extreme risk. And extreme risk you further divide into category A and B. So if you have 0 to 1 major ACVD risk factors and your lifetime CVD risk is less than 30%, you are low risk. If you have 2 major ACVD risk factors and low risk group with more than 1 moderate risk factor or lifetime CVD risk of more than 30, you are considered to be having moderate risk. If you have 3 ACVD risk factors, 2 major ACVD risk factors with more than 1 moderate risk non-conventional risk factor or more than 1 high risk features, then you are considered as high risk. Very high risk is already having pre-existing ACVD, diabetes with more than 2 other ACVD risk factors, and familial homozygous familial hypercholesterolemia. In extreme risk, if you have CAD with 1 feature of high risk group, or CAD with more than 1 features of very high risk group, or recurrent ACS, you are considered as category B. And if you look at the LDL targets, if you are low risk, less than 100, moderate risk, less than 100, high risk, less than 70, very high risk, less than 50, And in the extreme risk group, if it is group A, you should have target of less than 50, but optional is 30. But whereas in extreme risk group B, they ask for a LDL target of less than 30. So the LI guidelines has made the LDL target in extreme high risk group as less than 30. And that is naturally understandable because we Asians or Indians are at very high risk for coronary disease. Now, bringing LDL to such low levels, like in the Fourier trial where they kept even at less than 20 milligram per deciliter, does it cause any side effects? Now, if you look at this various levels of LDL starting from 20 to 80, if you look at the neurocognitive side effects, if you look at the rise in liver enzymes, if you look at the rise in muscle enzymes, non-cardiovascular death or hemorrhagic stroke, almost it is the same. So by bringing your LDL levels to say 20, 30 levels, you're not causing any harm to the patient. Is a low LDL something new? Almost all cholesterol in the brain matter is dependent on local synthesis. Previously, there was a myth that you need cholesterol is very important for cell wall synthesis, and if you don't have enough cholesterol in your blood, your brain function might be affected. But all that is a myth. Brain can prepare its own cholesterol. It does not depend on blood cholesterol for its well-being. Then hunter-gatherer populations who had no atherosclerosis even in the 7th and 8th decade of life, if you look at their LDL level, it is around 50 to 75. So they were quite healthy with 50 to 75 of LDL. And neonates, when they are born, they have an LDL values as low as 30 to 70. And that is the time when the brain develops maximally without being affected by the low LDL levels. So now if you look at the treatment algorithm by LI 2020 guidelines for very high risk patients, what he says is optimal control of diabetes and hypertension as per your respective guidelines in your country. Then start high intensity statins straight away in this very high risk and extreme risk group. Then reinforce lifestyle measures like diet, regular exercise, weight reduction, quit smoking, alcohol restriction. And still, if your LDL is even more than 50 lipids, patients with very high baseline LDL-C, very high CV risk need additional lipid. If you look at fibrate therapy, the main role is only in moderate to severe hypertriglyceridemia, and it is less effective on LDL cholesterol. If you look at PCO therapy. So the key takeaways from this presentation would be your residual risk of CV event persists despite optimal statin therapy, and it is all to the tune of 70 to 80%. Further agents are definitely needed in the armamentarium for lowering the better strategy. Statin intolerance should also be considered, and reserve agents need to be considered in such a scenario. Choose agents which have shown both LDL reduction and also CV risk reduction. Using an agent which only reduces LDL is not of use. In light of new evidence, bempedoic acid, novel agent, may be considered an important drug in the armamentarium, satisfying above requirement. And to talk more about bempedoic acid, we have Dr. Kaushik there. Thank you.
Great, thank you very much. I will just share my screen. Okay, can you all see my screen okay?
Yeah, we are able to.
Great. Okay. Well, it's a pleasure to be with you today, and thank you for the organizer for the invitation to come and speak to you today. It's always nice to speak to colleagues in India, and it's an exciting time. And I think you've heard very nicely in the previous two presentations the scale of the problem, the need. Clearly, the key messaging has to be around the need for combination therapy to get to lower cholesterol goals. Now, we're very lucky. There's never been a better time with so many different treatment options, and bempedoic acid becomes the fifth mechanism through which cholesterol is lowered and which reduces cardiovascular events. These are my disclosures. So why do we need to prioritize lipid management? Well, there are 18 million deaths a year from cardiovascular disease, most of which are going to occur from atherosclerotic cardiovascular disease. We need to move away from talking about cholesterol as a risk factor and cholesterol lowering as part of the solution to reduce the risk of cardiovascular disease. And here's a basic problem that we have. the disease is called atherosclerosis. It occurs in the vessel wall. The disease is not called hypercholesterolemia. And this whole process in the vessel wall will happen at different rates and different speeds, and it will rely upon inherited genetic vulnerability, differential vulnerability between individuals to the environment around, and this will happen over a lifetime. You can actually get away with depositing cholesterol in the vessel wall for many, many years before it causes symptoms. And that's the problem. It's a silent killer. There is no warning. And part of our problem is that healthcare systems, by their nature, focus us to treat older people, people with more advanced disease, and therefore part of that residual risk that we see is the delay in implementing processes that will reduce the risk of atherosclerosis. So healthcare systems, by and large, treat disease, they don't preserve health. And instead of starting here, we need to start here. But if you start late in the whole process over here, there's much more disease. So you've got to be much, much more aggressive. You start earlier, you perhaps can get away with less reduction, but through cumulative benefits achieved longer, you get to the same place. Now, why ACLY? Well, we published this analysis a few years ago, and what we basically showed here was that the genetic target for bempedoic acid is something called ATP citrate lyase, or ACLY. And if you look at nature's randomized trials, so here, genes associated with higher or lower levels of different pathways, which the drugs copy, essentially give you exactly the same. So if you use ATP citrate lyase or ACLY, HMG-CoA reductase, PCSK9, or NCP1L1, which is the target of ezetimibe, you get roughly the same benefit for a 10 mg per deciliter difference in LDL cholesterol over 50 years. So nature actually doesn't care how you lower LDL, which means you can add or subtract these, if you will, to achieve the desirable level of LDL lowering. Now, how does bempedoic acid work? Well, as you've seen, it works in the same pathway as statins, but 2 steps up, which basically means it will work by increasing LDL receptor expression, because what these pathways do is they produce cholesterol. So anything that inhibits any part of that pathway will reduce intracellular cholesterol. And it's that reduction that makes the body make more LDL receptors. So this is working. All treatments that we've got, by and large, work directly or indirectly through increasing the survival or number of the LDL receptor. The other key thing about bempedoic acid is that it's a prodrug. Statins, as you know, in some people will increase muscle symptoms, particularly in a dose-dependent fashion. Now, and these are taken up by skeletal muscle. The enzyme that activates bempedoic acid is only found in the liver. So this means that once converted into the active compound, doesn't leave the hepatocyte. So it's not taken up by skeletal muscle in the same way that a statin is. So you shouldn't get the statin-associated muscle symptoms that we see with statins. The other key thing is, because it works in the same pathway as statins, the percentage reduction in gain you might get with this drug depends upon how much statin you have in the background. I'll show you that in the data. So if we look at the large studies, and I led the Clear Harmony trial, this was the largest study that allowed bempedoic acid to be approved. It was an LDL lowering trial, and compared to placebo, you got an 18% on average reduction in LDL when you use this on top of a high-intensity statin, by and large. In the Clear Wisdom trial, it was fairly similar, so roughly in that 17-18% ballpark. But when you don't actually have statins in the background, or low or intermediate or infrequent doses of statins, you actually can get anywhere up to about 28% further lowering of LDL cholesterol. But we know that some people won't be able to tolerate any statins whatsoever. And what about oral treatment? Well, bempedoic acid may give you anywhere between 18 and 28% lowering of LDL. What if we combined bempedoic acid with ezetimibe in a single pill? And if we did that, what we would get is nearly something approaching a 40% reduction in LDL. So this is comparable to the type of efficacy that you'd expect with atorvastatin 40, for example. So the only thing that was left to really show, even though we've had 4 different approaches to lowering LDL, which showed reduction in clinical events, you basically have to show for regulatory purposes that the drug, not in combination with another drug, but that drug actually is the reason for a lower risk of cardiovascular events and is safe. So you've got to compare it with placebo. Now, we know that based on the mechanism of action, there's a group with a high unmet need. And in particular, these are the people who report statin intolerance. Now, typically in the past, we've said intolerance to 2 statins, but in this particular study, we said 1 statin, and if unwilling. So the physician had to say, they told the patient that their life could be in danger not taking a statin, and the patient said, I don't care what you say, doctor, I still won't take a statin. So this is really important because that reflects real world practice, unwilling or unable. Patients had to have a high LDL cholesterol, i.e. there had to be a need for LDL lowering. So we looked at primary and secondary prevention patients. So it's a pool population of both groups, comparing bempedoic acid against matching placebo, powered on 1600 4-point MACE endpoints. A key secondary endpoint was 3-point MACE, the typical endpoint that we see, and the minimum follow-up was 24 months. So this was basically what the patients had to sign off on. I can't tolerate medication called statins, and they have been told, they've signed that consent, and the provider has also provided that informed consent. There's never been a study that's done this way. This was the hierarchy. The primary endpoint was non-fatal MI, non-fatal stroke, revascularization, or coronary or cardiovascular death. 3-component MACE was MI, stroke, or CV death, and we have hierarchical testing. And what we do with hierarchical testing is you retain the power, that p-value that you need to generate until something is no longer significant. So after that, you can't really talk about anything else. So we had 13,970 patients recruited in 32 countries worldwide. And this was the time period that we did it in between December 2016 and August 2019. Median follow-up, 40 months, so about 3.5 years. And despite the pandemic, we've got really good rates of retention and where we've got vital status on the patient. So we actually had slightly more events than we had planned for. As you can see here, the 3-component MACE and also 4-component MACE, the primary endpoint. Typical of usually these studies, the patients are a little bit older. Unlike many of our usual studies, nearly 50% were female. And it's probably the highest study where, in terms of lipid-lowering trial, where we've had the biggest group of women actually recruited. LDL cholesterol was 139 at baseline. And that's not surprising. These people that are largely intolerant to a regular dose of statins. They've got a high unmet need. CRP is high. As you can see, 1/3 primary prevention, 2/3 secondary prevention, and a lot of patients with diabetes, almost a half. Now, as you would expect, because it's a placebo-controlled trial, that you see a large reduction in LDL in bempedoic acid treated groups, and then sometimes people will discontinue medication. It happens in every lipid-lowering trial, so you get a drift up. So in the other group, in the placebo group, you get a drop in of lipid-lowering therapies that will come in. So the actual difference in LDL diminishes over time. And when you do a trial, you want the difference to be as large as possible for as long as possible. So the effects I'm going to show you are despite a reducing difference between the 2 arms because of drop-in in the placebo group. But despite all of that, we saw a 13% reduction in risk of 4-point MACE and a 15% reduction in the risk of CV death, non-fatal MI, and stroke. You can see a 23% lowering in the risk of fatal and non-fatal MI, and almost 20% reduction in the risk of or the need for coronary revascularization. Fatal and non-fatal stroke tended to be lower, but wasn't statistically significant. So, for example, unstable angina real unstable angina, i.e. biomarker negative with ECG changes, was reduced by about a third. But again, we can't really put that into our algorithms because it came below fatal and non-fatal MI. Now, we've seen this with many lipid-lowering trials, that with better blood pressure control and other things as well, you have to go even longer than we did to show cardiovascular death and mortality benefits. By and large, that's the usual rule of thumb. So in this regard, we didn't see any statistical benefit for cardiovascular death or all-cause mortality within the context of this trial. But importantly, this trial is really about showing that this mechanism can reduce cardiovascular events, that this is just as good as any other mechanism, i.e. what matters is LDL lowering. If you look at treatment discontinuation, adverse events, these are really well matched. The things that we already knew were a 1% difference in gout due to uric acid competition with bempedoic acid in the proximal tubule, and a 1% difference in cholelithiasis. Now, this isn't gallbladder operations. This could be, for example, somebody complained of something and had an ultrasound scan, somebody else had something else. But when you lump these together, it comes under cholelithiasis. So there's a 1% difference of those. Importantly, tendon rupture between observed in smaller studies wasn't observed with any real difference. So if you look at the major subgroups, these are largely consistent. If you start breaking things down into multiple subgroups, some will always look a little bit better. And by definition, therefore, some will look a little bit worse. But essentially, there's a consistency of effect. So this should be something that works for all. So the limitations, of course, are this was in a population who was statin intolerant. But why would we believe that this works differently? There is nothing biologically different in terms of efficacy of LDL lowering in a statin intolerant population when it comes to cardiovascular benefits. There was obviously drop-in in the placebo arm, which may have reduced some of the benefits over time. And obviously, despite the pandemic, we did actually pretty well in terms of getting vital status and follow-up information. The bempedoic acid is the first oral lipid-lowering agent in a decade that has shown reduction in cardiovascular events. Now, this basically supports the notion that what matters is LDL lowering, and it gives us an option, both as an add-on, because in many parts of the world, injectable therapies are going to be very expensive, which means that basically we know as you move the targets, as was shown in the Lipid Association of India guidelines, how are you going to get there? Because statin, even at a high dose, is not going to get the bulk of your patients to goal. However, if you start to add in ezetimibe and bempedoic acid, approximately 2/3 of your patients on oral lipid-lowering therapy should get to lower cholesterol goals, for example, below 55, for example. So with that, I'm going to stop, and I look forward to the discussion with all of my colleagues. Thank you.
Thank you, Kaushik and Izilan, and brilliant presentation. And of course, from Dr. Kaushik Ray, we had one of the best presentations on this topic. Kaushik, I want to start with you. Between the bempedoic, say about 21% reduction, and say ezetimibe maybe about 18 to 20%, and particularly in Indians, Asians, it is supposed to have more reduction. So when you have to get the LDL down, first you have to consider ezetimibe and then bempedoic acid, or how is your prescription pattern?
Yeah, so I think we need to understand the maths, and I think that you start by assessing risk. And if you look at statins, will be first line unless somebody's statin intolerant. Once you've done that, you then, as we heard earlier about the LAI goals for LDL. If your patient is more than 20% away, if they're 20% away from goal attainment, you can calculate that. You can choose either. And the problem is most of your patients are going to be more than 20%. So actually, in that regard, if they're away from goal and they're tolerating the statin, I'd use a combination. So reduce the pill burden, have a 2-pill combination with ezetimibe and bempedoic acid.
The point, Kaushik, I'm just sort of emphasizing, because even in the LAI, I am also one of the advisor and the co-author of all these consensus. The addition of bempedoic we have done after the ezetimibe. Like even Ezilan has shown in his own presentation how the LAI, from the high risk to extreme risk, how to add on bempedoic on the algorithm basis, which you have also clearly mentioned. Considering that, I'm asking, or you think it is okay, bempedoic and ezetimibe adding is reasonable? I'm talking only about the LDL reduction. I'm not saying at the moment about the CRP and other things.
I don't think we need to look at CRP.
Yeah.
It's all LDL. And I think that it's reasonable to go with ezetimibe next because it's been around the longest, and then bempedoic acid.
Yeah.
But the problem is that most people will just add one thing in and wait and see what happens. If we are actively going to achieve goals, people need to feel confident about the benefit of achieving those goals and basically avoid inertia and waiting 2 years and then just see what happens with these patients. You can predict the maths. You're either going to be at goal or you're not. And you can use the maths to basically say, all right, if I'm within this, within that, then I'm going to go to this.
Other question, Kaushik, is many of our pharma giving 40 milligram rosuvastatin and bempedoic in combo, and you have shown in this clear studies, like when you have, say, a moderate or a low dose of rosuvastatin, and then adding on bempedoic. Like, we have one now, Lipid Association is doing one study where, triple combo, where we are using rosuvastatin, something like, intermediate, and then add on to bempedoic and ezetimibe. So you think 40 plus bempedoic is a rational combo? Because one of the limitation of statin is the intolerance. And then on the top of that, you combine 40 plus 180. How do you find this?
Well, I think that I would basically say that if you'd asked me years ago, I would have said something very different. So remember, we are interested in people taking medications chronically, long term. And today or tomorrow, they may be okay. And then we all feel confident. We say, hey, we'll see you in 6 months. We'll see you in a year because you're doing okay. What happens in that year? Maybe, they have a muscle spasm, nothing to do with medication. They go to Dr. Google. Statins, it's all this, it's all there. Stop the medication. So is that going to be more or less likely? In the days we had nothing before, no other options other than statins, I would have said, I want the 6% extra from 40 milligrams of rosuvastatin. Yeah. If you ask me today, going from 20 to 40 of rosuvastatin is only going to be another 6%.
Yeah.
But the synergy I get with the second oral agent is 20, more than 20%. So I would rather take more, pills, but reduce the dose as you have in India, and be more confident that my patient will stay on the medications.
Yeah, I think that's a very important point, Kaushik. In fact, we are in the study of this intermediate rosuvastatin, 180 bempedoic and 10 of ezetimibe. We have almost nearly 50-60 patients. Dr. Ramanpuri is, is our chairman of the Lipid Association, and possibly by September during our international conference, we are thinking of at least considering 300 patients. So, but you think this is probably like what we are using statin with ezetimibe, ezetimibe, bempedoic triple combo, you think will be a better way of going, particularly ACS situation? How do you find?
I think so. Yeah, I think so, because I think that with the highest doses, with the small body habitus, body mass, you're more likely to get some of the muscle symptoms, and then patients stop.
Yeah.
So I think we need to become much more smarter, and have that synergy with the different medications. The other really interesting thing is that what we've seen is that when we sometimes use the combinations, that there's a process called transintestinal TICE, transintestinal cholesterol efflux, that seems to get upregulated. So when you go use more than one pathway, you actually get a little bit more. You'll see this with some of the people that, from the average, there's the odd one that's going to get a much bigger response that you see. And we believe that one or two people may have a genetic difference where you can actually utilize this particular process. But I think it's going to be combination therapy, because the prices of the injectables are pretty high in India, aren't they?
Yeah. And in ACS, particularly Kaushik, you see this bempedoic acid is a big role, because even in the LAI ACS algorithm, we have asked for extended lipid profile at the time of admission, and 2 weeks later to repeat, and then work on bempedoic, or if people can afford PCSK inhibitor, that's other area. You think the ACS is a situation where we can use bempedoic is better? How do you find in your own research?
But there's nothing magical about ACS, and it's nothing to do with the pleiotropic effects. And I think basically it's the speed of LDL lowering, because if you look at Huygens and Pacman, it was LDL lowering quickly that started to thicken the fibrous cap, which means within 6 months, you've increased stability. And that's really, really important. So it's not just the plaque volume, it's stabilizing that. That, I think, is speed. The second thing I would say about the Indian patient, which I just remembered, I didn't show a slide of this because we're working on this to present this at the ESC, but we have shown that both through genetics and in the trials, that compared to statins, you have glucose neutrality. So we saw this with ACLY inhibition, that weight may go down, and we've seen this in the trials, and I'll show this data later on this year. Weight goes down just a little bit, but actually glucose metabolism, HbA1c, new onset diabetes. So again, for some patients with metabolic syndrome, in particular, with a higher risk of diabetes on statins, avoiding going up to the top dose because it's dose dependent, plus being able to use a couple of other more glucose neutral agents, may actually be quite good, because patients now increasingly going to go to the internet.
The other point, Kaushik, bempedoic doesn't reduce triglycerides significantly, isn't it? But it does the effect on the ApoB and the non-HDL. How do you find that, particularly for Indians? Our problem is non-HDL. How do you find that property?
So with any drug, so let's say I reduce LDL by 20%. The non-HDL will be about 2 to 3% lower, ApoB about 2 to 3% lower than that. So what we know, for example, is that the fibrates, which remove triglyceride, but did not stop those particles becoming small, dense ApoB. So think about prominent, where it all went up. And there was no difference in outcomes. So what matters is the cholesterol cargo in those particles. So how do you tackle that? So one way could be you think, oh, I'm going to basically reduce the triglyceride. The problem is you haven't stopped them becoming ApoB. So on the other hand, make more LDL receptors, have more LDL receptors available, and you pick them up at the level of clearance. So you wait for them to mature, but that's what statins do. When you add in ezetimibe, more LDL receptors. That's what bempedoic acid does, more LDL receptors. That's what any PCSK9 directed therapy does, more LDL receptors. The more of those you have functioning, the more you're going to remove particles.
Kaushik, the point why I was saying ACS, how speed you should reduce the LDL as in heart failure. Like, now our goal is to, give the optimization within 4 weeks. So also recurrent ACS events are more in the early part, 2 to 3 months. And that is another reason why, this will have. Azila, do you have anything to ask Kaushik on this topic?
Yes, sir. Now, the two places where we are using bempedoic acid is, one is if you are not reaching your target LDL or if you are statin intolerant. Other than this two, do you have any other role for bempedoic acid to play? Indication?
Heterozygous, familial heterozygous hypercholesterolemia. Three indications: statin intolerance, and when the LDL is not optimally controlled. And third is a familial heterozygous, this one, hypercholesterolemia.
And in people with ASCVD as well.
ASCVD,
you know,
how do you find
in clear outcomes? There was 1/3 primary prevention.
Yeah. Kaushik, how do you find this extreme risk? What LA has put, like ESC also, that high risk less than 55, and now LA, we have gone one step further, like between 30 to 50, and in extreme type B category less than 30. How do you find that approach?
Well, so I think it's a good thing. So again, if you'd asked me, so I guess the focus of your question is, do I think that's a good thing? And I'll say it's a good thing for the following reasons. So one of my roles is, although I'm a cardiologist, my title is Professor of Public Health. So from a public health point of view, whatever you do, people will never be that good. So if you said aim for 70, the average in your population will be 100. So by doing 30, the average is going to be about 55. That's the problem with implementation. So I think it's very good. By shooting for a lower goal, inevitably what you want doctors to do is think risk, one. Two, think combination therapy. So by default, when they try to implement it, the population distribution will move to the left for risk and LDL.
I'm asking you one provocative question. In primary prevention LAI consensus, which we now advocate for most of the Indian physicians, since our dyslipidemia is a little different than the Western, a low risk, we have put 100 as LDL, and moderate also roughly 100, But do you think for all less than 70 should be a good this thing? How do you find in a primary? Because you are in the public health,
I think so. So the big problem that we have is, what do risk factors actually tell you? Well, if you look at risk factors, what they're telling you is how much atheroma and atherosclerosis you have. That's all it is. If you look at the cholesterol treatment trial list, who got the biggest benefit in primary prevention per 1 millimole, 38 mg per deciliter? It was the lowest risk people. Why? There's less atheroma. It's softer. It's not calcified. It's much earlier in that disease process. As soon as in primary prevention, the 10-year risk starts to go up much, much more than that. If you're less than 1% risk, you get a doubling of benefit, almost 40%. If you are, 6% annual risk, let's say, then that benefit's now 20% because there's no more atheroma. How are you going to change that in 5 years? So I think we have to think about starting early. And if you start early and think lifetime, then actually monotherapy may work for many. But if you start taking a 6-year-old, even a primary prevention one, they've got a lot more atheroma. And you're going to have to do more. And risk is risk. Event rates are event rates. Doesn't matter what's driving it.
So cumulative effect, cholesterol years, legacy effect are the phenomenon, what we must practice, isn't it?
Exactly. Exactly. I mean, that's what, look at the cholesterol roadmap that I wrote. That's exactly what we put in.
That's exactly what we should be doing, Parsarthi, any delegate questions? Can you ask our panelist, Parsarthi, are you looking into the chat?
Yes, sir.
What is the question?
So the questions are basically a lot of what you've already covered in the discussion, but nevertheless, I'll go through them one by one. So Dr. Siddharth asks a question similar to what you asked, sir. Is there a role of combining moderate intensity statins, like a rosuvastatin 10 mg, with a bempedoic acid without the need for adding ezetimibe? Because what he feels from his practice is that the patient tolerance to therapy also improves. So what are your takeaways and what are your perspectives?
I think Kaushik has already answered. My answer would be for this. About the ezetimibe toleration, I think it is almost like a placebo-like drug. At least I don't know, Izilan may say our Indians, and I don't know, Kaushik, how much is using in UK. But I think, ezetimibe is a good drug for us, and side effect is hardly anything. And normally, in a combination is available easily. So I may say beyond statin, ezetimibe, and then, intermediate dose, what Kaushik and we were discussing, may be a way forward. And we are probably another 4 or 5 months, we are going to come out with the data, and we are going to present in our international conference, same thing.
Sir.
And which Kaushik also, said yes for that. Yeah.
Sir.
Yeah.
Sir, Dr. Kunal asks, sir, kindly advise us on lipoprotein A. What are the exact subset of patients who should be checked for LIPA levels and how to interpret it?
That Kaushik may be able to answer more detail.
Yeah.
We in LAI has given, at the age of 18, 20 years, at least that is the age at least to get the LPA done, or in a familial, high risk, etc., maybe earlier, the early part. In asymptomatic, without family history, at least at the age of 18, 20, we must get once LPA LP small a done, because since we have limited therapy, we have to keep LDL as low as possible in those patients. Kaushik, what is your reaction here?
I think that LPA, probably in all of us, we should measure it once in our lifetime, whenever that is. Earlier on, the better. But I think the people you maybe want to target, first of all, are who is likely to have it. One, if you've got a family history of premature cardiovascular disease. Two, if you yourself have got premature cardiovascular disease. Three, if your LDL is high, because it's reported in the LDL fraction. Some people don't have a truly high LDL cholesterol, but basically it's cholesterol in the LPA particle, which is LDL and ApoA added on.
So I think possibly Kaushik, bempedoic also would have a role where you have to get aggressive LDL, isn't it?
Yeah,
if
absolutely.
the LPA is more than 50 to 100, we want the LDL to be less than 50. So possibly bempedoic, though it doesn't directly reduces the LPA, unlike a PCSK inhibitor, but using that and in triple combo can get the LDL as low as possible. Agree, Kaushik?
Oh, absolutely. And think about it this way. So before we had the new glucose lowering treatments, what did we do? We controlled blood pressure, and we basically control not only the blood pressure, but we controlled lipids, we controlled LDL, even though that was not changing anything, with respect to the glucose levels. So basically, I think it's really important that people just sit down and recognize that it's about risk and atherosclerosis, and that's really key. So even though we can't touch LPA really at the moment with the current treatments that we have, they may happen in the future, you can still de-risk those individuals.
So everything revolving around risk and the target, isn't it?
Exactly.
Exactly, yeah.
We have just one more final question. But before the question, I would also want to get a statement by Dr. Prathamesh, who thanks each and every one of you for shedding light on the role of bempedoic acid in a post-MI management. He also gave a special thanks for explaining the perspectives of having an extended lipid profile at every 2 weeks. So after the same, we go to our last and final question. So this is from Dr. Arvind. Dr. Arvind asks about your perspectives on non-HDL cholesterol, as you rightfully said, and the perspective that the LAI has mentioned non-HDL cholesterol as a co-primary endpoint when managing dyslipidemia. So how should non-HDL cholesterol be looked into? Is it the 30 gap versus LDL, or are there any other perspectives to it?
Partharthi, I think it is very relevant since we are discussing bempedoic with Kaushik today and the real clinical use of that. We in LAI is given LDL as the primary target and non-HDL as a co-primary target and ApoB as the last one. Considering bempedoic particularly, non-HDL ApoB is reduced. So when the LDL target is not achieved, I think now we have got a better drug, and of course we have to look into other secondary causes also, like, high triglyceride, whether it's due to hypothyroidism or a drug induced, and all treatable things. We have to keep it in mind. Things like that. What do you say, Kaushik? Anything? And Ezilan, your comment on this topic? Agree?
No, I agree with everything you said. I mean, that's
Yeah.
exactly right. That's what I would do.
Yeah. I think if that is so, then we are nearing 1 and maybe 1 hour. Kaushik may be occupied with another webinar, because after the clear outcome, he might have, I don't know, which is this number today. He may be practically giving everyday webinar on this topic. I think as a moderator, both Ezilan and Kaushik has done a brilliant discussion on this topic, I think. And from your side, anything further?
Sir, thank you so much. From our perspective, it has been an academic feast. I mean, without mincing any words, it's truly been an academic feast. We are very sure that the audience who has attended this program would have benefited hugely and would have takeaways which would ultimately enhance their clinical practice. We take the esteemed, we have the esteemed honor of thanking each and every one of you to have enhanced their knowledge. Professor Shetty, sir, it was an honor to host you and get perspectives relevant to the Indian scenario for the clinicians who have attended. We also thank Dr. J. Elilan, who brought out the story of the need for non-statin agents so wonderfully. I mean, right from the perspective of how the Indian dyslipidemia is, be it CV risk, the aspect of residual risk, so on and so forth, and why the need. And finally, Dr. Kaushik Ray himself, who brought forth clinical aspects of bempedoic acid along with the trial slides, not just taking numbers, but also translating those numbers into clinical evidence and clinical practice. We also thank our audience who have taken their valuable time to actually attend this program and have takeaways. Audience, a huge thanks and a kudos for joining in at this particular point of time to enhance your knowledge. And last but not the least, we also thank our technology partners who have aided with the smooth streaming of this webinar. For the final words, I hand over to my dear friend, my dear friend Robin, to give his final words and a vote of thanks. Robin, please.
Thank you, Dr. Partner, and thank you to all the eminent speakers. On behalf of the entire Macroids team, I really appreciate the time you have given to us. And I'm sure this entire session would give a lot of confidence to all our doctors who have been, inhibiting from prescribing bempedoic acid to all of their patients. Yes, of course, there has been certain limitation in terms of the cost, but we are sure that in the coming few months or the coming time, this will definitely reduce over a period of time. So thank you so much, and thank you so much for joining, audience. We'll see you very early next time. Thank you.
Thank you, Kaushik. Thank you, Ezilan. Thank you, Parsuti, Robin, and all. Yeah, fine.
Thank you, sir.
Thank you.
Thank you,
bye.
sir.
Thank you. Bye.